SCOE Case of the Month by Randy Clark and Mark Gettleman. Patient is a 53-year-old female with a history of previous right rotator cuff repair. She never had postoperative pain relief, and further workup was concerning for a failed repair. Routine radiographs reveal evidence of a previous rotator cuff repair. Also note superior subluxation of the humeral head and acetabularization in the acromion. This is evidence of a catastrophic rotator cuff failure. MRI revealed a massive retracted rotator cuff tear. Note the patient had good muscle tone without evidence of atrophy. The subscapularis appeared to be intact, but the long head of the biceps was avulsed.
Right shoulder, lateral decubitus position. I've introduced the arthroscope. We can see we're underneath the rotator cuff. Supraspinatus is to the left. Here's where the rotator cuff is torn from. There's no supraspinatus attachment. We can see the suture remaining. Up here we can see the undersurface of the acromion where there's been the acetabularization of the acromion from her riding high with no visible supraspinatus tendon. As we rotate more posteriorly, we can see some of the retained suture. Down here we can see evidence of scar between the superior labrum and the undersurface of the supraspinatus posteriorly. I come in now with a radiofrequency ablator and release the scar between the labrum on the left and the articular side of the supraspinatus on the right. You can see there's a nice fissure between the two planes, between the rotator cuff on the right and the labrum on the left. By releasing this tissue, we'll be able to assess excursion of the rotator cuff. I then use a grasping forceps, and this is anteriorly back towards the rotator interval if the biceps tendon is absent, having had a tenodesis. We can see there is some excursion, but the rotator cuff remains tight and not able to be moved all the way to the anatomic neck. Following the glenohumeral work, I move into the subacromial space and again use my radiofrequency ablator. The MRI revealed that there was scarring to the undersurface of the acromion, and I'm now developing the plane between the supraspinatus inferiorly and the undersurface of the acromion superiorly. Again, I look to achieve the plane to identify the appropriate position. I'll then continue to use the radiofrequency ablator where I move towards the scapular spine, allowing improved visualization. We then move over to the anatomic neck, and I use an arthroscopic 15 blade to cut through the high strength suture in order to get this suture removed as the knots were intact. I can then use a grasping clamp to remove the cut ends of the suture to allow us to visualize the anatomic neck of the humerus well. Having completed the mobilization, I now work towards repair. We'll work on the anterior portion down towards the subscapularis and the anterior aspect of the supraspinatus, and this portion we can advance to the anatomic neck. We can still see there's a large central defect present, but we'll begin by repairing what rotator cuff can be repaired both anteriorly and posteriorly. I'll go ahead and insert a 5.5 millimeter PEEK anchor anterior to the most anteriorly cast anchor in the past. This allows us to have improved access, and we can then go ahead and set our anterior portion of the supraspinatus for repair. With a grasping clamp on the intact cuff, I identify the appropriate position for rotator cuff repair and begin our first anchor repair using a shuttle technique. As I go ahead and retrieve the shuttle device, I go ahead and pass my first suture through the rotator cuff, and we will continue to advance as we move through into the second suture, placing 2 stitches in the native intact cuff and leaving 1 suture behind for the graft jacket insertion. We'll then go ahead and retrieve its partner stitch and tie our anterior sutures. I then move to the posterior aspect where the infraspinatus was located, placing an additional anchor. Using a similar shuttling technique, I will go ahead and pass my sutures through the intact infraspinatus, advancing the infraspinatus as much as possible and working on my repair. Once both anterior and posterior anchors are inserted, we see here we still have a large U-shaped tear, which is very tight, despite releasing all the way to the scapular spine posteriorly and releasing through the coracohumeral ligament anteriorly. Having the patient previously failed a margin convergence repair, a decision was made to move forward with a allograft augmentation and reconstruction. I went ahead and passed the sutures through the native intact cuff and then brought the sutures out my lateral cannula where the graft was waiting to be inserted. It is very important to remain lateral in the cannula when retrieving the shuttle in order to prevent tangling the sutures as the graft is unfolded into the joint once all sutures have been passed. We'll then go ahead and complete the shuttle technique and retrieve the suture out the posterior cannula. The anterior sutures are retrieved out the anterior cannula and the posterior sutures are retrieved out the posterior cannula while visualizing through a posterolateral viewing portal, planning to bring the graft in from mid-lateral. We'll then go ahead and unfold our dermal allograft and bring this into the subacromial space under arthroscopic visualization. With the sutures well oriented and passed, we can go ahead and advance the graft in by alternatingly pulling on both the anterior and posterior sutures, which allows the graft to be visualized unfolded without tangling. Once the graft is unfolded, I go ahead and tie all the sutures circumferentially, and that leaves us with the anatomic rotator cuff repair now on the anatomic neck. We can see now the lateral margin of the graft with the purple line indicating the 50-yard line of my tear. I will then go ahead and place 2 additional titanium triple-loaded anchors just off the anatomic neck, maintaining appropriate tension on the rotator cuff. A similar shuttling technique is used to retrieve the sutures through the dermal allograft. It is a bit more difficult to use the standard penetrating clamp, as this tissue is a little bit tougher, and oftentimes you need to use a grasping clamp to hold the free edge of the graft in order to achieve suture passing. We'll continue with the standard shuttling technique, retrieving our shuttling device and retrieving it out in an alternative cannula, and go ahead and pass our high-strength suture through the cuff. This is the final view of our graft jacket. We've now completed the repair with our rotator cuff reconstruction using dermal allograft matrix. What we can see here laterally is I have 7 sutures through the graft to bone interface and multiple sutures medially, anteriorly, and posteriorly, giving excellent humeral head coverage. As we place the arm through a range of motion, we can see there's no evidence of impingement as the patient had had a prior subacromial decompression, and we can see excellent coverage. This is an additional view visualizing the graft now from the lateral portal rather than the posterolateral viewing portal, and we can see appropriate tension on our dermal allograft with excellent humeral head coverage. A crimson duvet performed laterally with a microfracture on the tuberosity to aid in a healing response, and without this now being under any tension, I believe a better chance for healing.